everyone. And first of all, I would like to thank you for opportunity to the DIVA to organize this and allow me and my team to be part of this important event. I had to apologize in advance. I see the presenters, the previous presenters have very powerful wording, very clear presentations, but come to my presentation is a lot of sensitive words or also sensitive pictures, which is I need to apologize in advance. My picture will be related to the some secret place that some people say, no, don't talk about it. Even some of the countries said, Dr. Nin, you're not allowed to draw the picture of this and things like that. But I need to bring this one into the discussions because we talk about this topic. So apologize in advance. I would like to ask you to keep your questions, ask a question, put in the chat box as much you can in terms of either technical or the program and things like that. Please do ask questions. So this is opportunity for us to discuss on this topic and then to openly talk, how can we move forwards to this, to work together in the future. That will be generate the discussions after my presentations. Yeah. And yeah, so next slide, please. So my task is to deliver 3 topics. One of them is on fertility care, the second on HIV contraceptive, and the last one on STI and HIV. So let's do the first one, the fertility care. Yeah. So as you know that infertility have impacted many millions people, also including in the Pacific. A lot of time, fertility is not priorities. People talk about infectious disease. People talk about nutrition and other things where fertility is left behind. If someone say that about the fertility, say, oh, you don't have enough sex, that's why you don't conceive, like they not take serious about it. This is, I'm talking about Pacific. WHO have estimated that 1 every 6 people, women in reproductive health age, worldwide experience infertility in their lifetime. Also, this is include, they have 2 types of fertility, meaning primary, that they never conceive. Secondary, that means they already conceive one, but later on when they want a child, they cannot conceive for some reason. So if we talk about fertility, that means we talk about 2 types. Primary, they never conceive at all, or maybe secondary, they have 1 or 2 child before, but now they cannot conceive for some reason. For fertility care, if we talk about fertility care, that means we discuss on preventions, diagnostic, and also treatment. But why I mark into red? Because in the Pacific, fertility prevention is almost close to 0. There's no awareness, community awareness, or educations talk about fertility preventions, because there are some work that can be done in prevention stage. I put the diagnostic. The diagnostic is very little of diagnostic. That's why I said the red one is a lot of work need to be done, because the diagnostic in the Pacific, in most Pacific Island countries, is a basic, just like normal screening, but not really go to fertility diagnostic. And it comes to treatment, again, it very little have been touched on that. This can be many reasons, can be priorities that I'm talking about, the government ministry, or maybe the NGO, all of us, they are not take serious, focus on the fertility treatment, maybe resources, maybe money, and things like, for a lot of reasons. We can discuss about this. So if we talk about fertility care for the 3 components, we have been just touched very little on the surface. We haven't addressed that yet. Next slide, please. So if you Google, if you go online, if you talk about fertility, you go right now online, you will see the picture of a woman maybe hold on the tummy, maybe the woman cry because she cannot conceive, or maybe a woman go to a hospital alone. Very seldom that you can see the picture of a man and woman work together, to address the fertility. A lot of time is a pressure or a symbol is focused on women, either smile or cry is there, and that majority. So look, because as we know that fertility is not one person. It's depend on men and women, but I think the symbol and they present on the website right now is mainly focused on women. And they have been changed over the year. In the past, there's no men at all. Now there are some men in there. Yeah. So it's a little bit changing. Thank you. Let's talk about the cost of fertility. So we know that to conceive, we need a man and woman to be there. If a woman alone is not, the fertility will not take place if a woman alone, unless you have some procedure that allow women to conceive, thing like that. So fertility is caused by different factors. We can talk a little bit later to touch on this. But they need male and female, and they look at reproductive system. Why I put the man and woman in the scale? They are equal responsibility. If it's no one heavier than others, even the woman carry the pregnancy, but fertility is equal from both sides. Next slide, next please. So my question is sexual intercourse is the only factors involved with fertilities. A lot of time when the couple or a woman or a man go to hospital, they will say, oh, you should have more sex. Oh, you have to say that. Is it sexuality alone involved with fertilities? Yeah. We can discuss after. The next slide, please. Let's talk a little bit about women and men. Just keep pressing. So the consumptions conceived of the pregnancy, the sexual act is the last one. It's the last one that involved with fertility. But to involve with those systems, we call reproductive health system. The reproductive health system is start from the head, the base of the brain, and the back of the head of the woman, and also a man as well. And the back of the man, where you put, on your back, upper of your neck, they have a gland inside. You cannot check the gland, you cannot touch or cannot anything like that. But it's in the back of your brain. They have a little gland there. We call hypothalamus. Forget about name. The name is very confusing. So that gland will be produce the hormone from there, and the hormone, if you look at the picture on your right, the hormone will be released to stimulate, to trigger a lot of organs. Start from your kidney, your liver, your heart, your skin. That's why, sometimes you feel that, oh, when I was young, my skin is very glow. Later on, when I'm old, my skin is a lot of wrinkle. Why? Because that gland also trigger the hormone, where it also stimulate your skin gland to produce something. One of the functions is triggered to your breast, go to the gland in your breast, but also one will trigger to your uterus as well. So all part of your body include your reproductive health organ, such as uterus, the breast. That's why in one point in time in the cycle, you feel, oh, my breast getting like tender pain and things like that. But later on, oh, my breast is okay, because the hormone that released from the base of your head, that gland, will be triggered to all organ, including skin, including reproductive health organ. So what happens when it triggered to the uterus, where the most common they call baby back, but I prefer to use the uterus if you all understand. They also trigger to fallopian tube, where the tube will control like a fight, where allow the egg to come from the ovary, because every month, because the trigger down, they also trigger to the ovary. The ovary is a kind of hands of both hands in the uterus. They try to produce the egg that try to produce egg, and the egg travel to the tube, go to your uterus, and if any sperm from male come in, then they will form a fertility. So this hormone will trigger to your ovary, your tube, and also with your uterus, where you talk about the what you call period, the menstrual period. So what happens if there's no sperm come in? Those eggs will be released to the uterus. They wait there, and then it's no is no sperm come in to form eggs, then they will drop down, shading as the a period, as a period is a monthly period. So what happened if a woman, now you understand that from the base of the gland until reproductive health system, any trigger, any effective or any system, any part of that, then the infertility will start. What happens if the base of the gland is not produce hormone or is not enough hormone? There's no trigger down to those to ovary or to uterus to create the hormone, and then create the environment that allow implant of the egg, the formation of the egg, the egg will start. So any system, even the base of the gland is not well, the trigger system is not work well, or even you go to the uterus, where what happens if the fallopian tube is blocked by some reason for the STI, especially for STI, or maybe something growth in the fallopian in the tube, because the tube is a size of, I think, very small, it's very tiny tube. If anything a little bit blocked, then the egg cannot travel, their fertility starts. So if you talk about infertility or fertility, we are not talk only the uterus make the baby. It's the whole system. So investigation need to be done to check that where is that, what part of that. Is it from the end of the system or middle of the system, or maybe the base of here? Some people will born up with abnormality, or maybe some injury, or maybe some other triggers. They are not allow your base of your brain, the gland work well, so the hormone will be less or not regular or something like that. So yeah, next slide, please. Now talk about the male. The male, you may, all of you, maybe most of you, see only male reproductive health system from outside. But now let's cut them into half, slide them into half. What happened, right? So the male reproductive health system is comprised of the penis, the end of the product. The testis is the sac under the penis, and also by tube, and then come down. And so the men have very clear, it's not complicated system, just like a woman. As like a woman, the men trigger hormone also from the base of the head, the gland, also from there. Again, affected on any system or anything from there is also affect the whole system. So so the investigation also need to look at the hormone, the pathway, whether they release in the right day, the right time, and all of that. But this is, I'm talking about just the reproductive health system. Any block of the tube, the male in all the time, not like a woman in monthly. You have a monthly period where the egg release in monthly basic. But for the men, they produce all the time. They look like a factory, the meal factories. So they produce all the time, where the testes, they produce semen. They produce semen in there and mix with you can see the like a water, we can, the fluid in there, travel through the tube, they call the vas deferens, go up, and then connect in the below of the bladder, mix some more like a lubricant from some gland there, and then come out through the penis. So they produce sperm. Let's say sperm all the time. Is the amount of sperm is depend on the age, also some diseases, or maybe some substance, like people take alcohol will be affect that as well. So any obstruction in that reproductive health tract, they also cause infertility, where the sperm, then they cannot come out. They only can see the clear water come out, the semen, but it's no sperm inside. That also cause infertility. Also the hormone, like I just mentioned, the hormone disorder, like can be the hormone from the base of the gland or some part of the body, can be the hormonal, or maybe they call testicular failure, the testis. So in men, they have 2 testes, but some men born with abnormality as well. They have just one, but sometimes they born with the testes, but they call the testes is not functioning. They can have ejaculation, they have sex like like the normal man, but the testes, like a factory, is not produce a product. So they will have come out as the clear substance, but it's no sperm there. We call testicular failure. In some men, very rare, can born with zero sperm, like all their life. So that we cannot correct as well. They call azoospermia, that means zero sperm. Also, abnormality of sperm functions. Next slide, please. What we mean by abnormality of sperm functions. It's not every sexual intercourse or ejaculation will have a baby. Yeah, they need the quality of sperm. We need the quality of eggs to be together. As I mentioned, is the quality equal partner here. So in each ejaculations, the man they can produce. This is called the normal sperm count. The normal sperm count, that means one ejaculations will have around 39 million sperms. If you put in suva, maybe flat suva already, 39 millions. Also, they should have the sperm concentrations is around 15 million sperm per milliliter of sperm, or even small. That means the whole ejaculations is around how many mil, 1.5 to 5 mil, and things like that. If they take out 1 mil, they should have the sperm around 15 million, where 40% of them moving, not come and sleep and stay for nothing. So 40% of them can swim, that means they can move, and at least 4% of them have a normal shape. The normal shape, that means the shape that I put on the right side. They have to be a smooth head, oval, have the tail to swim, have a neck and things like that. But if any sperm come with a square head or a round head or something like that, that's what the lab, they say that abnormal sperm shape morphology. That means the shape, thing like that. So they have to be 4% at least have a normal shapes. That's what I just described. And also the sperm volume and also the pH. pH, that means the concentration in there have to be normal. So when we do investigate of sperm, that means we look for this criteria. And who can do that? It's not the man come to you and say, oh, I have normal sperm count, my sperm is oval head. No, it's not come from him, it's come from the lab, because they have to look at the number, the movement, is it you can swim in front or swim backward and things like that. So the lab, they will certify that normal sperm count because I have seen this, the criteria. Next slide, please. So my questions to you is, do the healthy, good-looking men have a normal sperm count? You can see a lot of men, very handsome, masculine, very healthy. They say, oh, he have very good sperm count. No, you cannot judge by looking. Yeah, by looking. The research show that the science study, that many studies put that no significant related to the appearance and the sperm count. We may see that the man is very healthy, maybe his nutrition is good and things like that, but it's no correlations with the sperm count. So appearance is not. Yeah. So the external appearance is not related to the sperm count or overall fertility. We may say that his good nutrition, his good skin complexion, maybe he don't have any other disease and things like that, but not correlation. So having a masculine man or a good-looking man is not related to the normal sperm count. Thank you. Next slide, please. So the challenge of the fertility care, I put a long list here. If I talk about the challenges, we will stay here for the next 2 days. But I just list a few that what will be the challenges that we face. Also, the first one is a clear understanding about sexuality. A lot of people said you have sex more often, you will get baby. Some of them say that, oh, you know, when you have sex in the morning, it's more fertile than the afternoon. So majority in community, even some misunderstand in the healthcare worker as well, will advise the wrong information to the couple about how to conceive, how to increase fertility. So the clear understanding about is sexuality. Also, we talk about when is fertile day, when is non-fertile day, what area, what factors that affect fertilities and all of that. So we don't have clear understanding about the sexuality. Also, the role, gender, and norm that men and women link to fertility. A lot of time we put a lot of pressure to community, put a lot of pressure to women, stigma, like, you know, if she cannot conceive, or even she conceive a male, but they want a baby, a female, if they want a baby male, the woman also get the blame. They should understand that the role of the fertility is equal, the man equal woman. No one able to select, okay, you have sex in the morning, you make a baby boy, or you have sex at night, make a baby girl. But the science in the lab, they also exchange the genetic. We can talk a little bit in the next slide. They'll be able to sex selection, which is some of the international sex selection is illegal. To do that, but we can discuss because we are in safe space. We can talk about anything here. So the role, gender norm play a big role where put certain pressure to women and not linked to a man, and we're not sure who play a big role, and a lot of time it put pressure to women in terms of fertility. Also, access to services. Just talk about Fiji, who really have, we call the hub of the Pacific. Where can you receive, where can you go to access to comprehensive fertility care? It's very difficult. This is, I'm talking about in the middle of town, the big hospital, the tertiary hospital here. But what about the woman stay in the outer island, in the rural services, where information is not there, access to services is not there. So it's a big issues. The access to services is a problem. Not only about care, talk about informations, counseling, and treatment for the fertility care. Yeah. Also limit of specialized care. Which place in Fiji here that go to specialized care that I can go and talk about fertility care? Maybe some services in Oxfam Clinic at the back of CWM. I worked there for many years, but the service is very little. You provide counseling, you just do a little bit, but not even cut into the structure that we discuss about the cause of infertility. We don't have that as well. Also, the social and culture, or maybe policy barrier. A lot of policy that I mentioned is focused on family planning, focus on something else, infectious disease, disease control, and other things, the NCD, but the fertility, we don't have, maybe it's not priorities. No one talk about it. So the priorities of the country, also stigma associated. You all may know that if women cannot conceive, they are the one, she's a bad girl in the society. Right? So she cannot conceive, she's a bad girl, she must be getting cursed from her father. All of this, so it's stigma. So a lot of time, a lot of cover up, a lot of pretending, a lot of shame, a lot of blame, even go to the violence. I witnessed so many women have been violenced by a husband, by a family, or by a mother-in-law if she cannot conceive, but they don't understand that conceive is not her alone. She cannot get pregnant alone. She needs to be a man to make her pregnant, and the man have to have that quality to make her pregnant. So there have been, I witnessed violence and abuse, and how can we address this? Before come to the provide services for treatment and things like that, this one need to be tackled. So maybe just to share with you the treatment options. Yeah. Okay. So the treatment option, you will see that some of the text I put into the red and some is blue. We talk about counseling. Counseling is the basic counseling that we provide. Yes, so talk about reproductive health, fertility, and lifestyle, but not counseling on other options. Yes, so that is available. We talk about the treatment. We also see treatment for STI and other related issues, but we are not treatment of hormonal replacement or regular the cycle or trigger the hormone at the base of your brain. We don't even talk about that. We talk about the simple treatment of STI and things like that. The investigations, for your information, investigation for fertility have 3 levels. The basic and community-based, and a little bit high level hormonal, and also investigate to genetic and things like that. But for us, we only do for most Pacific Island countries, including Fiji, we do a basic blood test, maybe hormonal test, which is very expensive, but full investigation is not available. The management, we only manage the infectious disease. We are not manage hormonal therapy, which is play a big role to trigger to the gland, whatever the pathway that wrong, that not, not normal, will not trigger that as well. Also, the surgery for specific, like for example, the block tube, the tube block, or the sperm block, the canal, we don't have that with. We don't have IVF, is the intra-fertilizations, where the egg and the sperm and combine and then implant to your body. And also we call insert an IUI. It's another services, also is not available. So yeah, so management is very basic. Next slide, please. So the treatment option I put in red here, these are the some other options like egg, sperm donations. We don't have that as well, the services, or embryo transfer or donor transfer. We don't have that services. Like, for example, if the man not able to produce sperm, we able to get sperm donation and then put with the woman who have egg already there and then implant back. So we don't have that services, or freeze the egg or freeze the sperm. And for some other country like Asia, the service is kind of more cheaper and available. But here, a lot of people turn to go to Australia, which is very expensive. So I'm talking about availability, the cost, where, and what the law, will not all of these line up blur. Next slide, please. Thanks. So the second one I'm going to talk is about family planning and right. So let's clear about, sometimes we talk about family planning, sometimes we talk about contraception, but what these two are different. We talk about the family planning is a broad aspect about decision, a planning. I plan to go to market, I plan to have a children. So if we talk about family planning, we talk about the process. If we talk about contraception, we talk about the tool that you use. Like I use condom as the to prevent my pregnancy, then we talk about contraceptions. I use injections to prevent pregnancy. Then we talk about contraception. So a lot of time we talk about, oh, I use family planning. Family planning is a process. Contraception is a method. It's a tool that you use. We have all type of method in here. Start from condom, barrier to reversible one, and to non-reversible, like a tube tie or vasectomy. Next slide. Okay. Yeah. So whatever method, whatever method that you use, the previous one, previous. Yeah. Whatever method that you use to prevent pregnancy, that we call that to prevent pregnancy is a process we call the family planning. The aim is to prevent sperm to meeting age. That is the aim. Yeah, it's nothing else. So the aim of using contraception is to prevent these two to get together. Next slide, please. Next slide. Oh, okay. So we have, like I mentioned earlier, they have varieties of the contraceptions. It starts from below a condom, male condom, and then go to the next level, go to hormonal like injections, and then go to the implant or loop and things like that, and also talk about the sterilizations. Why they're ranking the low and the high? Because they're ranking from least effective to the most effective. Yeah, the higher, that means most effective. But either most effective or what is that means we can prevent, can more effective to prevent pregnancy. Next slide. Next. So the benefit, as we all knows already, so just to improve maternal child, mother and the baby, not only a woman, the mother and the baby as well, can allow women to do spacing to prevent complications, also to economic stability. This is allow women to educate, to work, earn money to support themselves. As you know that economic dependence is good, but also can be a challenging where you depend on some people's money. So this allows women to earn their money and can empower them and stabilize their living. Also empower individual, the woman, especially the girl, if they're still go to school and things like that, empower them, help them to go through this while they're not ready for pregnancy. Also, the family planning, birth control allow them to make decisions when they want to have it. Say that, oh, I will choose family planning for 1 year and then I will have a child next year. So for them to plan properly, to plan with their family or to plan with their husband. We should not have children within this period, but we should have children in that period. So family planning is allow them to decide when to have it, the size of the family, and also the space between the children, between the child. Next slide, please. So what we talk about the risk. So what we talk about risk, what does it mean? How often that the woman should have baby? We say, oh, 3 months, you can have pregnant again. 2 years, you have pregnant again. It's not clear cut. It's not the clear cut how long. Some people will say 1 year, some people say 2 years, but this is the definition that when you have a short, we call IPI, inter-pregnancy interval, that means define 18 months between one live birth, the live birth, and the next pregnancy. If you can keep that space for the 18 months, then you consider as a interval, the healthy interval that allow a woman have a body, ready. The woman allow the woman body to prepare themselves to have the pregnancy. So what happens if she have pregnant and then next few months she have pregnant again, and then again, then the risk of pregnancy is significant, either during pregnancy or after the pregnancy. That means physical, nutrition, and when you have a consecutive pregnancy. In the short term, because the woman involved, the woman also share the food with the baby. Then she have, some nutrient, only 50 come to her. During the delivery, a lot of bleeding involved. So she have a risk of anemia. Also physical and emotional, because pregnancy is not only involved pregnant, it's also involved the hormonal change, the hormonal change and things like that, and also trigger to feeling emotions. She also linked to emotional strain. Also the stress during pregnancy is enormous. Also increase the surgical. They also in the short term, if the woman have frequency pregnancy, the evidence show that it's a risk of surgical for her complication and also severe and other diseases as well. In the long term, also impact on cardiovascular disease. This is I'm talking about hypertension and also heart disease and also the kidney disease as well. They also want research show that the source I put in the slide also decline of the cognitive functions as well when you have multiple pregnancy, or short period of pregnancy. Next slide, please. So to access family planning, as we know, is a fundamental of human rights. So everyone have a, it's a fundamental of human rights to decide freely, responsibly, the number of children they want, the space they want, and the time they want. Also, it's a right for international law where everyone, men and women, should have a right to access to information, educations, and involuntary. No one force them, to voluntarily have a right to do that as well. Then the question that when did that right start? What age that you have a right to access to the family planning? They mean that the soon they are capable to getting pregnant, to have children, they should have access to services, start from information and also other services as well. Next slide, please. So the challenge here, I'm put in two boxes, one from the community and one from service provider. From the community, the cultural religion, they say she's too young to have family planning. Or below 16, below 18 should not give family planning. So something like that. So the cultural religious barrier, we have put that to prevent young people or even the woman who not married woman not allowed to get family planning. So the cultural and religious barriers, some of the religion not allow a woman to use family planning. Also limit to health services, especially the people who non-educated women or the women live in a rural community were not able to access to the services. This I'm talking about information and services. Geographic isolations or maybe stigma. If the women are not married, she maybe think twice, try over 10 times before she come to the services. Because a lot of community expect that family planning is just only for women, married women, not for everyone, or should be, for adult, not the young, young people. Also, the issue is about confidentiality in the Pacific is a big issue. The judgment, when you are people with disability, I'm talking about, or maybe we talk about the lesbian that the lesbian couple we're talking about, and things like that. So we worried about confidentiality, the judgment from the healthcare workers, and what to expect. Like this is a lot, and there's a lot of lists that I witnessed in the community. Also, the services. The family planning have changed. All health services, not only family planning, they have been changed. The technology changed, the science changed. Also, the family planning change. They kind of advise the safety and things like that. For example, now we have pill injectable, but we have now cell injectable is coming out. Cell injectable have been conduct consultation in a few countries now, just like the one that you inject and for 3 months, and currently healthcare workers give you injections. But the upcoming family planning is the cell injectable, where the woman will be trained by the healthcare worker. They take medicine home and then come to the time to receive the services. They don't need to come. They just inject that one. They call cell injectable. This is happened in Kiribati. Fiji also look at consultation, and also I think some Solomon Island, there are a few, and also PNG. They start consultation, but cell injectable is not come out this year. They have been there for many years already. They work in Africa and many countries in the Southeast Asia. Yeah. Next slide, please. We have time, right? The next one, I just have a next few slides, and I will keep the time for the discussions. My task is to look at the STI and HIV. I mean to put STI, including HIV, because HIV is part of STI. HIV should not stand alone because HIV is one of the STI infection. So sexual transmitted disease and HIV is a significant public health problem in the Pacific. So in the Pacific, they have been there for some time, but look, a lot of time we say that, when you guys, maybe DIVA have the same experience, ITBF will have the same experience. When you guys talk about SRH, teaching SRH in school, use distribute condom, you bring STI, HIV to our community. But this one just to share with you, STI have been there for so many years. They have been traced back for 2,000 years already. Syphilis outbreak have been recorded in 1494. So the STI have been there for a long time. But maybe because of science is not able to detect those virus, then we don't know. And you may surprise that for the next 10 years, you found that some disease that currently occur now, but because of science, the testing, the research is not covered the topic. We are not talk about that region. But if we talk about STI, they have been there many years ago before we distribute the condom, before we put sexual education in school. So, and also look at the HIV is one of the STI. They have been there for many years from 1959, and also the publications on AIDS, meaning the case that report in the late stage of HIV, had been there from June 1991 that publicly say that disease called AIDS. Before they call something else, they call like LAV, because they found that the person that got AIDS, full-blown AIDS, have lymph node enlarged in their, neck, leg, and things like that. So they're not called HIV, they call LAV. Or they call something else, but they call LAV because they found the person who died from HIV have lymph node enlarged. So they call, this is a medical term called lymphogranulomatous because they saw the lymph node enlarged. Okay, LAV. But later on, they found that their disease attack immune system. That's why they call HIV or AIDS. So, but we talk about disease have been a long time ago. What we're talking now about how to prevent and how to address this one only. Yeah, hope this is makes sense to you. Next slide, please. So the most common, press one more. So the most common of STI, they divide into the type of the pathogen. If you look at on the table, they divide into bacteria, virus, and parasite. So like we talk about chlamydia, pigeon tona, right? Gonorrhea tona, all of that, they belong to bacteria. Most of the disease-caused bacteria can be treated with simple antibiotic. The second row, in the middle row, called viral, that's why HIV comes from, HIV, that's caused by virus. Human papilloma virus, HPV, or herpes, or hepatitis, they belong to virus. Most of the disease belong to virus, they are uncurable. So we also the parasite, then we have lice, big lice, or they also consider as a STI. They all come in, we classify in the group because for the medical, we easy to treat. Which group they belong to, then we easy to treat. They come with all type of shapes. Some shape is so beautiful and spiral, rod, round, and all of that, all type of shapes. And how we know that they're bacteria, how they know they're chlamydia, because the shapes. Yeah. So only the lab they're able to do that. Yeah. Next slide, please. So STI in the Pacific, we know that STI prevalent in the Pacific is very high. It's one of the highest. The research has been done because second generation surveillance done in the 7 Pacific Island countries, including Fiji, including that, found that STI, especially gonorrhea and chlamydia, is very high. And as you know that for this gonorrhea and chlamydia, it's very simple, easy to treat. But if you keep it, you non-treat, it gives you a lot of complications and the severe complication and can go to death as well. Chlamydia and subtype of chlamydia, the chlamydia have many types, but in some type of chlamydia can cause cervical cancer, can lead to cervical cancer if you treat, if you non-treat and keep it there. Also that we have limited all knowledge of preventions. We have stigma associated with the people who go to STI clinic. We should appreciate that they come to the clinic, they get treated and can be prevented. But instead, the knowledge and the stigma have been addressed to people who enter to the STI clinic or seek the STI treatment. This stigma is also, I'm talking about stigma from community, but also healthcare worker as well. The number 4 is inadequate services. A lot of people don't know where to go. If I got STI, where can I go? They keep there until a really late stage. They cannot handle anymore. If they have an ulcer, their ulcer eating half of their penis already, then they will come to the hospital. Yeah, because they don't know where to go. They're scared to go. They fear stigma and so many reasons. The services, if we talk about the main island, like Viti Levu, maybe something that they can access, but what happens if they in Laugrum or somewhere? Where can they go? So services is very important, and I'm talking about effective services. Yeah, effective services. So those people need to be trained, need to know how to handle that. Otherwise, they give you injection, and after injection actually they caused by virus. Virus is not work with antibiotic. you can give more, the infection will be, develop further. So inadequate services, also the emerging drug use. Now we know that HIV is linked to different pattern now. In Fiji, before it talked about HIV transmit to unprotected sex, but now we talk about HIV transmit through injected sharing needle for the drug user, something like that. So the pattern of the epidemic is different. Also, the last one I talked at the health system capacity, the skill of person that I already mentioned. Sometimes people have a skill, say, oh, I don't have drug, the right prescription, ask you to go and buy from somewhere. If you already were shy, you don't have money, you don't know where to go, you still there, you keep the prescription and you still carry on infections. So I saw that supply, commodity supply is very important. Next slide, please. I think the last one. Next one. So I think all of you know the transmissions. If you have unprotected, most of the infection transmit through the unprotected sexual intercourse. You sharing needle. If you use just one needle by yourself, there's nowhere you can get in. I'm talking about sharing the needle with infected person. Also infected mother to their child. Also the needle stick injury among healthcare workers. Also look at physical contacts. Also, like I said, the herpes. Herpes is caused by virus and non-curable. A lot of people say that, oh, I'm okay to have this STI as long as I don't have HIV, but some other STI is non-curable and it can lead to severe complication as well. So like herpes is non-curable and also transmit to the bloodborne transmissions. Yeah, next one. So I think to understand the understand a mode of transmissions, then we know how to prevent, right? So it's easy to discuss on that. So the challenges is that a lot of STI has no symptom. They don't have symptom. You have infection until you have complication, but no symptom. But these people already, the disease already progressed on that person, but also this person can pass to others. So one of the challenges is the research show clearly that if the people have symptoms, it's much easier to treat. When the people have no symptom, they're reluctant and they're non-compliant as well. When you give medication, when they don't have symptoms, they never complete their medication. So STI is 80% of chlamydia, especially among women, have no symptom. Also, the lack of clear knowledge of the STI transmissions. A lot of time I come across people said, oh, I just have sex for the first time. I may not, I don't think I have STI. But they don't know that either one time or 5 times or 10 times. If you have unprotected sex with infected person, you got it. So the clear knowledge on STI, where the testing and also the treatment. Behavior is one of the things. A lot of people understand those transmission completely. They have condom in their pocket, but when they go to have sex, there's no condom there. So behavior change is not applied for some people. So your responsibilities. Also, we talk about a lot of alcohol in the drug involved with that, stigma, and where to get the services. For provider, I have a list of things of the chain of that. The person need to be trained how to handle it. They have to have medications. It is currently a lot of health service provider is centralized, meaning put everything in the central. Only certain place provided services. But what happened if maybe 1/3 of the people in Fiji stay in a rural area? If you put the services in central, what happened to the peripheral services? They will say, oh, I refer to that, but how many people will come to referral services? So that one of the challenges and commitment, the funding, the coordinations between national to the peripheral, also the update policy and guidelines. And we have to understand that the epidemic of STI and HIV now has changed from unprotected sex now include inject drug use. Yeah, and we have to be proactive. The healthcare provider cannot just sit in one place and say, yeah, I will treat everyone come. But what happens? People are hesitant to come or they don't come. That is very important to reach out to those people. I think that I think that's all. Yeah, that's all my presentation. So I hope I'm not go too fast. I hope that you catch something, and now handing over to Mumtaz.
No, back to Tamani.
Back to Tamani.